Hello and welcome to this video clinical dialogue, evidence-based management of progressive MS. I'm Shiv Saida, Professor of Neurology at Johns Hopkins University School of Medicine. Joining me in this conversation are Dr. Scott Newsome and Dr. Bob Fox. Dr. Newsome is an Associate Professor of Neurology at the Johns Hopkins University School of Medicine in Baltimore, Maryland. Dr. Fox is a neurologist at the Mellon Center for Multiple Sclerosis at the Cleveland Clinic in Cleveland, Ohio. My thanks to you both for your involvement in this important continuing medical education activity. The past 2 decades have seen advances in the treatment of relapsing MS, but we still have a lot of work to do in terms of our management of progressive forms of MS. People with progressive MS accrue disability slowly but continuously, and often in the absence of distinct relapses or other evidence of overt inflammatory disease activity. A small number of people will progress from the onset of disease, often referred to as primary progressive MS, although it is somewhat more common for people to enter a progressive phase of the disease subsequent to a more typical relapsing course, and this is referred to as SPMS or secondary progressive MS. In this clinical dialogue, we'll take a look at how we conceptualize progressive MS, its recognition, diagnosis, and current treatment approaches. When you complete this course, we'd like you to consider enrolling in the accompanying eCase challenge, where we'll use several case scenarios to apply these topics. So I think, first of all, a great place to begin, and I might start with you, Scott, if that's okay, is really kind of setting the stage in terms of defining what progressive MS is and what does progressive MS mean to you, as an example.
Progressive MS, as in your intro, you described a little bit of it, sort of this progressive neurological worsening where there's huge unmet need, and I know we'll talk about this later, for therapeutics. There's a bunch of different definitions that are out there, but in my sort of clinical practice, what I will typically use, at least for secondary progressive MS, which the audience may know, this is an extension of relapsing onset MS, are individuals who will have neurological worsening without intersposed relapses for at least a year. I will say it's very tricky, though, to determine when that cut point is for people that go from relapsing remitting to secondary progressive MS, because some of our patients maybe have cognitive issues, don't realize they had a relapse, and that could sway things a little bit. But the purest definition, at least with SPMS, is really to have at least a year of slow neurological worsening without inflammatory activity, i.e. relapses. But again, in clinical practice, my usual point is to follow people closely, especially if they have that worsening over that time period, to make absolutely sure that this is what we're dealing with. Now, primary progressive MS, I think, is a little bit different because from the onset, people progress, and strict definition is they don't have relapses.
Yeah, no, I think that's really useful. I mean, Bob, I'm curious. I mean, some people tend to differentiate SPMS and PPMS quite dramatically. Some people tend to think of them, and indeed all forms of MS, as being somewhat on a continuum. I mean, do you think it's even important to differentiate SPMS from PPMS? I mean, and do they even really clearly delineate themselves from one another, or even relapsing forms of MS for that matter?
Well, first, let me thank you for the opportunity to join you all. It's a pleasure to try to dissect this very complicated aspect of this disease. So progressive MS is an unusual medical condition in that the patient sort of defines it. Patients come to us and say, do I have progressive MS? And we turn the question around to them. And we say, do you have MS symptoms that are gradually worsening little by little over time? It's most commonly manifest in the legs of decreased endurance with walking or with climbing stairs with items in their hand, like a briefcase, a laundry, or groceries, or things like that. So when does it start? Depends on what the patient is doing and what the patient demands out of their body, whether it's their legs or their arms or their cognitive function. So it depends how demanding they are. So I have a patient who's had otherwise stable relapsing MS for many, many years, but his long distance running duration has gradually decreased. He used to be a marathon runner, and then he developed a foot drop in the 22nd, 23rd mile of marathons. And then it slowly became earlier and earlier that he had a foot drop. He has a known cervical cord lesion from his MS. But when he's not running, he's completely asymptomatic. But when he runs, he notices over the years this gradually decreased endurance in his legs and an earlier manifestation of his foot drop. So when did progressive MS develop with him? Well, it was certainly over the time when he was running and he noticed the decreased duration of his ability to run long distance. But what if he weren't a runner? What if he didn't exercise as much as he did? We wouldn't know that he has progressive MS. So progressive MS is somewhat defined by how much a patient is pushing his or her own body, which of course makes it a little bit difficult because a couch potato patient may not notice he or she has progressive MS because they're not expecting as much from their arms or their legs.
I tend to conceptualize MS as being on a continuum. And for simplicity purposes, I kind of think about PPMS as being people who just never really manifested the relapsing phase of the disease. And I think that it's easy to get at SPMS, which is where people kind of have had relapses or they've been demonstrating evidence of overt inflammatory activity, and especially for inactive SPMS, and they're just no longer doing it, and then they're just kind of gradually accumulating disability. I kind of want to get down on this a little bit because from a diagnostic point of view, I think where we really have a lot of challenge is differentiating a subtype, which is, I think these are arbitrary subtypes, and I could be wrong about that. And then there's actual progression. How do we even confidently arrive at the diagnosis of progressive MS? I'm gonna flip that over to Scott a little bit because I'm curious to see how Scott approaches that too.
Yeah, no, I agree with you, Shiv. Bob's example is probably one of the most difficult ones because we know as our patients get older as well, there's an element of age on top of, old injury, which you could look at, well, is this progression or is this just because the person's older, they're not compensating as well for the disability that they have? And so I will utilize diagnostics in this setting just to be sure that the person is having progression without inflammatory activity. And that helps me define, okay, do we feel good about progression independent of relapse activity or inflammatory activity in general? And why is that important? Well, it comes down to the therapeutics we have available in our armamentarium. I think all of us would agree if there's someone that's having worsening neurological status, we're going to, of course, rule out other things. What's their vitamin status? Do they have B12 deficiency, copper deficiency? Are they experiencing, now they're a little bit older, spinal cord stenosis, which can sometimes mirror progression in our patients. So that's sort of my number one approach. Make sure there's nothing else to explain this worsening. And then number two is really trying to do a deep dive. Is there evidence of ongoing inflammatory activity that's macroscopic that we can see? Because in my view, that will help determine next steps with therapeutics. If someone's on a therapy right now, do they need to escalate? Do they need to do a lateral switch to a drug that has a different mechanism of action? Do they need to be put in a clinical trial, right? Because we do have clinical trials that are ongoing that are looking at, progressive MS in general. So that's a lot of information. I don't know if that answers your question, but that's sort of my way of thinking when I see someone who has an example like what Bob, went through.
Yeah. So you mentioned two things that really caught my attention there, and I'm curious what Bob thinks about this. You mentioned macroscopic inflammation, which for me really kind of gets at overt inflammatory activity that there's evidence for, either in the form of relapses, which tend to be much less common, obviously, in the true progressive subtypes, or new T2, new contrast enhancing lesions. But then you also mentioned age, and then you may not have evidence of macroscopic inflammation, Bob, but age could be an important way to kind of help differentiate whether there's somebody still at risk, right, of being in the adaptive inflammatory phase of the disease.
Well, somewhat. And so diving down into those two aspects, we know that the focal inflammation, which is manifest, as you both were alluding to, new lesions on conventional MRI and focal discrete relapses. Sometimes are a little fuzzy to differentiate from pseudo relapses from a ongoing infection or other things um, that can elevate symptoms but not be a true relapse. But going back to new lesions on MRI or a focal clinical relapse, we know that that's from new infiltration of peripheral white blood cells into the brain, the spinal cord, the optic nerve. And we know our therapies are very effective at decreasing that. And so if a patient has that, we know that we need to think about changing therapies or considering whether that is the right therapy that they're on and moving to a different one. And we hear every day patients say, Doc, you tell me my MRI is stable, but I know I'm getting worse. And the answer is yes, both are right. Your MRI is stable. There's no focal inflammation, but you are getting worse little by little over time. And understanding and describing that and recognizing the two different aspects of MS, I think it's an important thing to convey to patients. Now, in terms of aging, Scott, I'm going to push back on you a little bit. And you were saying, well, is it aging or is it progressive MS? I think they may be a combination of the two, in that previous lesions will have accelerated aging. And because of the pathology going on within those old scars, there is a quickening of the normal aging. And so we may not be able to disentangle whether it's aging or whether it's an old lesion, and that it may be both together, that an old lesion has accelerated aging. So in that area of the spinal cord, it may seem like it's 75 years old, even though it's only chronologically 55 years old. It is an older area of tissue because of that previous injury and the accelerated aging that comes.
Yeah, no, I agree with that. I think we need to learn a bit more about the aging impact on the nervous system with and without MS, right? But I do agree with you.
I think one thing I would point out, just from an age thing in terms of chronological age versus biological age, I think it's extremely important. I think there's one other thing though, is there's also an age effect on the immune system and immunosenescence. And that's kind of one of the other aspects that I was kind of trying to maybe get at. And when we look at some of the phase 3 clinical trial data, for example, for ocrelizumab and in its effect to PPMS, that there may be a predilection for it to work a little bit more effectively in people with PPMS who are younger. And I just say younger as just a general, under the age of 50, has been a kind of a broad maybe way of identifying people who are still at risk of being in that typical adaptive inflammatory phase of the disease. And I usually believe the patient is not telling us, hey, doc, I feel like things are not right and things are slowly getting worse. Scott, do you ever feel like, is this more of a retrospective type of a diagnostic?
Without a doubt. And this is where the field has to move towards developing and finding better biomarkers that help predict where the person's going. And, I know there's a lot of excitement around neurofilament light, a lot of excitement around certain imaging metrics that may be able to give us an idea. I don't think that's going to be the end all be all, but it is retrospective, at least in my view, at this point in time with the tools that we have. And honestly, I'm not very good at demarcating who has progressive MS versus those that don't, especially if they've had MS for a long period of time. I don't know. I'd love to hear from either of you two, whether you have pearls of wisdom that could help me and others. But I feel like that it's really retrospective at this point.
It's absolutely retrospective. And although we have an increasing number of tools to measure patient performance, patient neurologic function in the clinic, at the end of the day, their ability to carry a bag of groceries or a briefcase or a basket of laundry up the stairs and feeling like it's taken a little extra effort, or I have to stop at the second step before the top, or I have to stop at the top of the stairs before I can continue walking, or before I could walk up the stairs and just continue walking. That is a very granular assessment of their function. which we just have too clunky of tools to be able to do very well. So I defer to the patient and I ask the patient, what did you used to do that you're struggling with now, that you're not able to do? Now, cognitive function, it's tricky because patients' assessment of their cognitive function is often different from an objective measure or care provider's measure. A lot of patients will say they have cognitive impairment and it's not clear that they do, or it may seem more because they have sleep disruption or they have emotional disruption like anxiety and depression, that if we can get those better, their cognitive symptoms may improve. So the cognitive is a little bit harder, but arm and leg function is a little bit more reliable as a patient self-report for us to define progressive MS.
Curious, Bob, do you think, I mean, clearly the progression by itself delineates itself from classical relapsing MS in the sense of, right, it's just a slow accumulation of disability. That's how we conceptualize it. Are there any imaging features in real time that actually are useful that to help differentiate? Because bread and butter, classical PPMS and SPMS are typically inactive, right? Yes, some people do have new lesions and some people have contrast enhanced lesions, but for the most part, is there really a way to, from an imaging point of view or any other metric currently in our hands, to differentiate the progressive subtypes, or it's really mostly based on history and feel and exam?
So the short answer is no. The Magnum's group, which is a European-based imaging group, published a consensus paper about a year ago or so that looked at this of, can we use imaging to understand progressive MS versus relapsing MS? And aside from new lesions on the conventional MRI, new T2 lesions or new GAD lesions, there really isn't. Now, there are some things that seem to be associated with that. So patients who have more brain atrophy are more likely to have progressive MS. Patients with a higher T2 lesion burden, so a total volume of T2 lesions on a T2 weighted image, they are more likely to have progressive MS. Patients with slow expansion of their T2 lesion burden, the slowly expanding lesions or cells, SEL, they are more likely to have progressive MS. But these are just associations and are just correlations. They are not diagnostic by any means. So right now, we are really left with the patient story, the patient history, and our then doing additional exclusionary tests to ensure there isn't something else going on that looks like progressive MS, but actually isn't.
So we've kind of said that there's a clinical differentiation, maybe not so much of an MRI differentiation, but pathobiologically, Scott, we do know that there are different disease mechanisms that are more, I shouldn't say that they're probably more abundant and more prominent in the progressive subtypes of the disease as compared to the relapsing subtypes of disease. Any thoughts on that and this kind of this spectrum of the way that the biology of the disease may change over time?
So we certainly know what progressive MS is not. It is not focal infiltrating lymphocytes from the circulation, coming out of the circulation and going into the brain and the spinal cord. We know that because that's what relapsing MS is. So what is it beyond there? I'm going to say we don't really know. Accelerated aging may be a part of this, which may or may not include the innate immune system. We have mitochondrial exhaustion, metabolic exhaustion from chronically denuded axons, the metabolic stress of a damaged, scarred nervous system that caused an accelerated decline.
I think the data that exists right now certainly shows this imbalance of innate being more active over the adaptive within progressive MS.
And actually, one of the challenges is for in general in people with MS, as we survey them over time as they get older, we often start to see sometimes new lesions developing, and we're not even sure whether they're MS-related lesions or they're related to other age-related factors. And I think can be a bit of a challenge. Very broadly, just in terms of approved treatments for SPMS and PPMS, and then we can just say active SPMS is really just a relapsing form of MS, and so everything that's licensed for relapsing MS is technically available for that. The real challenge is inactive SPMS and PPMS. So let's talk about both active SPMS, inactive SPMS, and then just typical PPMS.
Well, let me start with the easier, and that's the active MS. So when patients have what appears to be a clearly defined MS relapse, or they have new lesions in MRI that look like typical MS lesions, well, we do know that those patients are adding further injury to their MS central nervous system. And so most people will agree that those patients should change their MS therapy to something different. Now, some of those patients are on no MS therapy, and then we counsel them to start an MS therapy. Some may be on one MS therapy, and we counsel them to shift to a different MS therapy, often a more aggressive therapy. Sometimes it's moving laterally to a different class. Most of us would change to a different class if there's persistent focal inflammation on a therapy. Now, that sounds easy, but we do also have to warn the patient that the gradual little by little insidious decline that they also have may not be and is less likely to be slowed or noticeably affected by changing therapy. So patients will come in a year later and we'll be all happy they didn't have another relapse and their MRI is stable, but they'll say, "Doc, my legs are still getting worse little by little over time." So it is important to convey to the patient that what we think are the reasonable goals of the therapy. Now, in terms of the progression part, whether it's with the active inflammation that we're already treating with a different therapy or just progression without active inflammation, our therapies are not very helpful in slowing that decline. So we have had some trials recently, ocrelizumab in primary progressive MS, siponimod in secondary progressive MS. But the later analyses from both of those trials show that the predominant benefit is in the patients who are younger, who are more likely to have, who had focal inflammation, either relapses in the secondary progressive trial or active lesions at entry into the trial for the primary progressive ocrelizumab. So right now, our current immune modulating therapies really don't have much of an impact. So what do I do in clinical practice? The older the patient is, the longer it's been since there's been evidence of active focal inflammation on either imaging or with a clinical relapse, the less likely I am going to suggest that they change their current MS therapy to something different in the setting of gradual little by little decline that looks like progressive MS.
I'll give an example, like a 53 or 54-year-old male who maybe had one or two new lesions, who's got PPMS, and you're going to put them on ocrelizumab after extensive counseling, acknowledging that the data for it is modest at best, and that's my own kind of view of things. How are you going to even determine what the effect is of that treatment in the clinic space? How are you going to monitor that person? And what are you going to do 3 years later, after which there's been no change on MRI, and maybe there is still some progression? It's I know it's a tough, unfair question from the outset.
No, but this is a real world question. We deal with this. And you can even take the secondary progressive MS patient that hasn't had macroscopic inflammation, and I put them in sort of the same bin, at least I do. In that scenario that you mentioned, for me, I would feel comfortable putting someone on a B-cell depletion for a couple years. But to answer your question more directly, and what are you going to measure? What's your measure of success? I go back to, well, what is the activities of daily living for that individual? Do you have a number of time points where you've seen the person where you can get a gestalt of their sort of trajectory of worsening, and where hopefully, if it's helpful, you have sort of a flattening of that worsening, even if it's not completely flat, but you hear from the patient, oh yeah, maybe the marathon runner example that Bob had mentioned, over the last 2 years, I went from X miles to this mile, and now you put them on a therapy and they've sort of flattened out and they are about the same as they were prior to starting their therapy. Now, you could also, to play devil's advocate, we know in progressive MS, some people will plateau for a while and then they'll sort of go back to worsening. But some of the things that I will measure or try to measure is sort of what's happening in their activities of daily living. In our clinic, we do timed walk. So measuring things that are mainly, I would say, ambulatory in that scenario. And then for some patients, depending on what their disability is, let's say cognitive function, hopefully you have a few different time points where you can measure cognitive function over time. But it is hard. And you mentioned 3 years. So my hope is within that few year time period, there'll be something else available that maybe will work better. But it's really hard. It's really hard. And then just not to forget, again, number one, making sure there's not anything else that's causing the worsening or coexisting with MS and causing the worsening. And then I'm a big believer in non-medication interventions like rehabilitation, because I do feel like that helps. And then one last thing, and I'll be quiet, is treating medical comorbidities. So Shiv, you already mentioned if someone has, let's say, poorly controlled diabetes, hypertension, they're smokers, there's plenty of data now in MS that we know that actually, increases the rate at which people will decline. And we even have imaging studies that support that with gray matter atrophy.
Well, Scott, you're making some good points, and there are three big areas that you're touching on, which I think are often forgotten in managing patients with progressive MS. Where they come in, they say, "What drug should I go on?" And say, "Well, we don't have great drugs," and they don't do a whole lot. But there are three main areas that I think patients should keep in mind. One is those comorbidities, and this goes back to the accelerated aging. So we know that patients who smoke have a faster course of their MS. We know patients who have diabetes have a faster course of their MS. And we know that patients who have vascular risk factors have a faster course of their MS. So we can't get rid of their diabetes necessarily, but we can encourage them to get it adequately treated, to treat their hypertension, to treat their diabetes, to encourage smoking cessation, because we think those things actually do have an impact. Secondly is the symptoms. A lot of times patients have symptoms which are making their life less enjoyable than it would be otherwise. It can be anxiety and depression. It can be spasticity, it can be sleep disruption from their pain, from their spasticity, or from the ruminations of their anxiety that keep them from sleeping, and then they're very fatigued during the day. So there is often ongoing symptoms that they may not be thinking about, but if we help them realize that and develop a treatment strategy for them, it can improve their quality of life. And then exercise. Exercise is critically important. And we know from many of the basic science studies with animals looking at remyelination and recovery from injury, that the animals that exercise do so much better with whatever treatment they're given than the patients that don't exercise. And we need to consider that with our progressive MS patients as well, adapting their exercise to what they're able to do, but to work with a physical therapist to design and adapt a exercise program, because that can also have a great impact on their progression and on their quality of life, on their mood, on their sleep. And it has all these connections to other aspects of their general medical health.
I think there has been some emerging data at some conferences this year for BTK inhibitors in terms of what is a BTK inhibitor actually? Like, could you like fill me in on that? Or
Yeah, so BTK inhibitors, it's a class of drugs that are inhibiting the BTK or the protein tyrosine kinase enzyme. And so some of these within this class cross the blood-brain barrier, get into the brain, and there is the potential for them to interact with microglia and with astrocytes to have a benefit on the inflammatory milieu, the innate immune system side of that's resident within the central nervous system. So there are several ongoing phase 3 trials with a couple different BTK inhibitors. which are looking in progressive MS. They're also looking in relapsing MS, but for our purposes here, they're looking in both primary progressive and secondary progressive MS to see if it has an impact. And these are phase 3 trials. So they're looking at clinical outcomes to see if there's a benefit on the progression. So whether it works through the B cell follicles, whether it works through microglial activation or astrocytic changes, those studies wouldn't necessarily tell, but I would say, let's see what those phase 3 trials show. If they do show a benefit, then it's worth further dissecting. Okay, well, then how are they having a benefit within the brain? Is it on the microglia? Is it on the B cell follicles? Where is it having its benefit?
Well, I'll just make a quick comment, even though we're talking about progressive MS. The relapsing MS studies with the PTK inhibitors, if you look across the board, they don't seem to be as robust at shutting down sort of conventional macroscopic inflammation markers, i.e. clinical relapses, and then even on imaging markers of new GAD-enhancing lesions. And so you could look at that at two ways. One is, well, it's a modestly effective drug. Maybe it'll work in progressive MS, maybe not, who knows? Or you could be maybe a little more optimistic and say, okay, let's focus and use these only in progressive MS because this is what it's going to help the most. Or an older patient who you're concerned that maybe is at greater risk for infections, they still have relapsing MS and you want to de-escalate because of immunosenescence. But I agree with you, Bob, we have to go beyond, I think, the conventional measures. We have to look at what's happening at the microglia, at the astrocytic level, the follicle level, novel imaging markers.
Well, and we also have some old therapies. So we have simvastatin, which is one of the statin therapies that showed promise in a phase 2 imaging-driven trial out of the UK. They are now doing a phase 3 trial. So they're doing a large phase 3 trial in almost 1,000 patients, over 900 patients with secondary progressive MS. So that's an old drug that showed some promise in phase 2 trial that is moving forward to phase 3. And we are also seeing, and hopefully in the next year or so, we'll see the results from an ocrelizumab trial in primary progressive MS of older patients, of more disabled patients, really diving down into, is there benefit of ocrelizumab in patients a little further to the right in terms of their disease progression. And so I eagerly await that trial's outcome to help understand the benefit. And then the final thing, we always have to think about the safety, as we were alluding to. We might have benefit, but at what cost? We know many of our therapies will increase the risk of infections. And so as we study patients more deeply and for a longer period of time, we'll get a better sense of that risk benefit, particularly the risk of infections, responsive vaccines, and things like that.
I mean, I think you both make some really interesting points. I will say for myself, in terms of the BTK inhibitors, I think it's interesting and kind of fascinating that we have so many of them in phase 3 trials. I mean, there's evobrutinib, tolbrutinib, fenbrutinib, and remibrutinib on the way. And then there's another 3 on top of that from other companies. It's like that I'm aware of, and there's probably even more. And it's normally in the MS space, what we've dealt with is maybe, one drug coming new to class rather than a flurry of drugs coming to a class at one time. And there are potential differences among these compounds in terms of CNS penetrance. And then you raised something really interesting, Scott, about maybe a class of therapy doesn't have to be as effective in the relapsing phases of disease. And why should it really have to be as effective in the relapsing versus progressive phases of disease when we think the pathobiology may be a little bit different? And it does raise to mind some other compounds as well. I mean, I always find it interesting when I look at the teriflunomide data as an example in the phase 3 ofatumumab studies and even in the obinutuzumab studies. And the actual inflammatory effect is not that high, but yet you sometimes get this really nice NFL/brain atrophy effect. And with that in mind, as an example, within that DHODH class, there's vidofludimus calcium, which is a related compound to teriflunomide, which has some potential, differences in terms of side effect profile that seems to be advantageous. And that, therefore, also being studied in progressive MS. Go back to microglia. There's one other thing that's being studied, and the data is excellent for it, at least in my opinion, and that's ibudilast. And so, Scott, I'd love to hear your thoughts on ibudilast and its effect on brain atrophy in the SPRINT MS clinical trial.
Well, I can't wait to hear Bob's because he was integral in that clinical trial program. But I will say, when the primary results read out, I was really caught with excitement because, if you look at the curves with the brain atrophy between ibudilast and placebo, probably the biggest difference between groups when we look at cutting back the rate of brain atrophy in those that were on active drug than any other clinical trial we've seen. I will say, what couched my enthusiasm a little bit is the other measures that were captured during the clinical trial program, the secondary outcome measures. We didn't see any major difference, but it was a smallish trial, a phase 2 trial. And, those that do clinical trials, we know that you may not see secondary outcome measures hit.
Well, ibudilast is a small molecule orally available that I helped lead a phase 2 trial funded by the NIH, placebo-controlled in primary and secondary progressive MS. We had about 50-50 a breakdown of primary progressive and secondary progressive MS patients. And over 2 years, progression of whole brain atrophy was a primary outcome, and there was a 48% slowing of progression of brain atrophy in the treated versus the placebo patients. We also saw a benefit on MTR, one of the secondary outcomes, and we also saw a benefit on cortical atrophy, another one of the secondary outcomes. We did not see a benefit on OCT, looking at retinal nerve fiber layer, although Shiv has done additional analyses with more sophisticated analysis tools to find that there is a benefit as measured by OCT on the retinal pathology in progressive MS. So that added further evidence. What was a little bit disappointing was that neurofilament data was flat. So there was no benefit of treatment with ibudilast on neurofilament compared to placebo. Now, what we've learned from other progressive MS trials is that absent active inflammation, there isn't a benefit of treatment on neurofilament. And indeed, neurofilament doesn't seem to predict or correlate with progression. Again, in the absence of active inflammation, either relapses or new lesions in MRI. So it appears that neurofilament, although we were excited about it as a biomarker for progressive MS, does not appear to be a useful biomarker for progressive MS outside of focal inflammation. So where's ibudilast going now? I don't know at this point. The company that was developing it was looking for a partner for conducting a large licensing phase 3 trial, and I've not heard that that has moved forward yet. There's one additional learning that we took from the ibudilast trial, which was quite surprising to me. And that is when we split apart the primary and the secondary progressive patients. And again, we had about half and half of primary progressive and secondary progressive patients enrolled into the trial. What we found is that the treatment effect was almost entirely driven by patients with primary progressive MS. Now, up to that point, I had considered primary and secondary progressive MS much more similar than it was different. And that there was maybe some subtle differences, but they were highly overlapping. But surprisingly here, the benefit of ibudilast on the imaging metrics were driven almost entirely by the primary progressive patients. And why was that? It was because the primary progressive patient placebo group progressed more quickly than the secondary progressive placebo group. So yes, there was a treatment benefit, but it was in part because the placebo groups performed very differently in the primary progressive patient population than the secondary progressive patient population. So at least the data from that trial suggests that there may be more difference between primary progressive and secondary progressive patients than I had previously appreciated.
Could I just ask you, Bob, between those two groups, the PPMS and SPMS, I know you allowed first-line therapies if patients were on it to get into the study, like glutathione acetate as an example. Was there a difference in sort of the patients that were on a platform therapy amongst those groups? I would assume PPMS patients were maybe not on those therapies or maybe less likely to be than the SPMS, but was that taken in consideration?
Well, enrollment into the Abulas trial allowed patients who are on injectable therapies to continue their injectable therapies, and that included the interferon therapies and glutathione acetate. And not surprisingly, there was a higher proportion of patients with secondary progressive MS who are on those injectable therapies, and a lower proportion of patients with primary progressive MS who are on those injection therapies. So because that was so differently allocated, we weren't able to disentangle whether it was being on the injectable therapies that affected the treatment response, the differential treatment response, or having primary or secondary progressive MS, because they were pretty much separated already by their disease subgroup. So we don't know if there was an impact or an influence of having ongoing, even platform injection therapies, which we don't think are highly effective, but may have been effective enough that it did confound our readout of that trial.
I'll make a point for secondary or even tertiary outcome measures in these clinical trials, because I think these are going to be incredibly important for our progressive clinical trials. Reason being, some of the things that we already talked about. The conventional imaging does not seem to change, right? We didn't mention EDSS, which I'm impressed. We went in this entire time without mentioning the EDSS, but that typically does not really change much, right, in our progressive cohorts. If you look at the MSFC, depending on the components, often those don't change very much either. So, thinking about other things like, albeit they may be a little more subjective, but patient-reported outcomes, I think, are becoming more important. What's the patient's experience? Another thing which hasn't caught attention as of yet, some quantitative dynamometry. So there are small studies showing that, for example, hand grip strength actually is associated with more progression than what we see in the relapsing group.
So, Scott, any thoughts on repair strategies, and is there scope for us to move forward with that? Are we making advances, or what are your thoughts on that?
Yeah, no, it's a great question. It's going to be sort of a clouded answer. I mean, I'll just say from the 50,000-foot view, short of a cure, I feel like we're going to have a cocktail of interventions for our patients, regardless of whether you have this subtype relapsing remitting MS or you're labeled as progressive. I mean, there have been a couple studies, earlier stage clinical trials looking at things like clemistine fumarate is one example, to see if whether that is a candidate agent for neuroprotection, remyelination. There have been thyroid analogs that are, being tested in early clinical trials that, by way of how thymomimetics work on the body, there's some interest because of mitochondrial stress and its impact on that, the putative remyelination capacity of that as well, at least based on animal models. So I think we're going to have to look at this in sort of different buckets. And it's really going to be putting all the buckets together to help protect our patients from having neurodegeneration. So again, clouded picture, muddy water, but I do feel it's important to at least introduce to the audience that it's going to go beyond just the immune system. especially for our patients with progressive MS.
Yeah, Bob, how do you feel about that? A cocktail of, let's say, a preventative, which I think of as a drug that's just really good at targeting the immune system, something that's primarily neuroprotective, independent of inflammatory pathways, and then like a restorative type of approach. Is that the future, do you think, or is it somewhere in between?
Well, I think we need to tailor our treatment to where the problem is. So we've already talked several times about patients who have ongoing focal inflammation. They should be on one of our current immune therapies to decrease that focal inflammation. Patients who have chronically denuded axons, if we can develop a therapy that encourages remyelination, we should use that therapy. In patients who have activated microglia that is driving their progression, we should use a therapy to target activated microglia. Patients who have metabolic stress and mitochondrial exhaustion, treatments that may target supporting the metabolic process and the mitochondria should be chosen. So the trick will be figuring out in an individual patient what their disease needs to have addressed.
And with that, we've come to the end of this clinical dialogue. We talked about how we define SPMS and PPMS, how to recognize a person with these MS subtypes, and our current and evolving treatment approaches. After this activity, we invite you to participate in the accompanying eCase challenge, where you'll have the opportunity to apply what you've learned in this clinical dialogue in a clinical scenario and receive additional CME credits. And speaking of CME credit, to receive yours, please be sure to complete the post-test and evaluation. I'd like to thank both of our expert faculty, Dr. Newsom and Dr. Fox, for joining me. And I would like to thank you, our audience, for participating in this important continuing medical education activity. I'm Shiv Saida. Thank you for joining us.